All right, so hearing disorders, we're talking switching gears from the eyes to the ears. So the ears have a, anatomy-wise, right, we have a external ear, middle ear, and inner ear. The reason we bring this up is because when we did talk about hearing disorders, they either affect the inner ear or they affect something else, right? The inner ear is the sensory neural portion, sensory neural hearing loss. So the sensory organ, which is the, what was this thing called? The vestibulocochlear, right? The vestibulum and the cochlea, right? One is for hearing, one's for what? Balance. So if the balance portion is off, you get symptoms of vertigo and nausea, vomiting, right? So that's why on a car ride, right, your eyes and your ears expect information to line up. So in a car ride, if you're reading a book, information is coming from your ear that you're moving, but your eyes don't feel it, so you get thrown off and you get vomitatious, right? So the middle ear, that's what connects with the inner ear, and that's, you can have perforation of the membrane, you can have an inflamed membrane from otitis media, right, with fluid that's built up in here, and you'll talk about this more in pediatrics, where you have all this fluid building up with recent viral infections and bacterial infections. But also the little ossicles here, they can get inflamed over time, or you just have plain old what inside your ears? Plain old earwax inside your ears, and that's going to block the transmission of sound into your brain. So it can either be a mechanical problem, like a conduction, right? You can't conduct sound into your brain because there's something in the way. There's wax there, or these ossicles have arthritis and they can't move good, and they can't conduct the information into the cochlea or vestibulum, right? So conduct means to draw energy from, like electricity, right? So you're conducting things. And then inner ear problems, again, would be a sensory neural problem. So it's either a sensory organ problem, so S for sensory, right? Or it's the nerve itself, right? The nerve itself looks like a W, but the N nerve is going to be, there's a problem with the nerve, or it also could be where the nerve ends up. Where does the nerve end up? Where does your vestibulocochlear nerve, cranial nerve 8, eventually end up on? It's a trick question. It's going to, by the way, eventually it's going to end up on the temporal lobe, right? And so that's like with strokes, might have some deficits, like with talking and speech. That's hearing things is part of that equation. All right, so sensory neural loss versus conductive loss is something we can easily ask a SATA question on, right? So conductive versus sensory neural. So do they have cerumen? Oh, which one's that? What is cerumen? That's just a fancy word for wax, right? That'd be a conductive hearing loss, right? They have a problem with the organ itself, right? The sensory organ itself. That's a sensory neural loss, right? So we'll talk about that. And then tinnitus will usually happen with strain on your ears, right? And we'll talk about how to fix that. Some people have tinnitus just at baseline and have to take medications to stop tinnitus. And then finally, we'll talk about Meniere's disease. Meniere's disease is just fluid overload of the ear, of the inner ear. All right, so there's too much fluid inside the vestibulum. There's too much fluid inside the cochlea. So the cochlea itself has little hair cells, and the hair cells need to be able to flow back and forth. If you're fluid overload, they're not going to flow. They're just going to be tight, right? So that's the idea. And then you get vertigo because now we're starting to involve the vestibulum. Okay. So hearing loss, all right? So it does occur with age. So it's a part of aging, just like presbyopia happens with age. Presbycusis happens with for hearing loss. Are we checking off on Jet? What's going on? All right. So yeah, presbycusis, right? If it occurs in someone younger than 60, it's usually a problem, right? They damage their ears somehow, right? So it could be, again, aging. It could be hereditary. It could be something congenital. The reason why they can't hear is a congenital issue. But occupational, recreational, right? So people usually go to like these rock concerts, I think they're called, right? And they listen like right up front, and it's like super loud, right? So they do that. Even just, I think the previous slide said like what, 7 seconds or 7 minutes, I think, can cause a permanent damage, right? And it's not the amount, right, of decibels. It's usually the duration of decibels that causes problem, right? Of course, at a certain point, it's going to cause, like someone as far as a handgun next to your ears, that's going to cause some permanent damage, likely, right? And cause ringing in the ears, which is, what's the fancy word for ringing? Tinnitus, right? So occupational, there could be autoimmune, demyelination, right? The multiple sclerosis can cause it, can cause demyelination of the nerve itself. So that'd be called what? Sensory neural or conductive? That'd be sensory neural. The nerve itself is getting deteriorated, right? All right, and then we have meds, and meds are always going to be sensory neural because they're damaging the cochlea itself or the nerve itself, right? So antibiotics, we know those, right? We got vancomycin, we got our macrolides and aminoglycosides. Those are literally damaging to the ears, right? They are ototoxic. All right, chemotherapy or cisplatin, our platinum agents are all ototoxic, and again, that's a sensory neural or conductive. Sensory neural, right? They're really damaging the cochlea itself, right? NSAIDs, especially aspirin, is damaging to the ears at high doses. Loop diuretics, ironically, are reversible. You can give it super fast and they have tinnitus and then it goes away. And then we got PDE5 inhibitors. We'll talk about those next week, right? Those are Viagra and erectile dysfunction meds, right? So these are all ototoxic meds to be able to recognize as causing what kind of disorder? What kind of ear problem? Is sensory neural. So we're in blue here, right? So it's causing damage to the cochlea or the vestibular. In this case, these meds are ototoxic. They're damaging the cochlea, right? So types of loss, again, conductive. So conductive means that we have a lesion in the membrane. We have a membrane that has poked a hole in it, right? We have a hole poked in the membrane itself. It's not going to conduct, right? So a drum only drums when the membrane is drawn tight, right? If it's not drawn tight, there's no sound, right, or little sound. So that will obviously be a conductive loss due to trauma or due to, eventually otitis media can rupture the membranes too. All right, so that's conductive loss. Also, earwax can be in the way. What's an FB? It's a Facebook invite or a foreign body, right? So a foreign body is in there. So right here we got a nice big huge bug that's living in there, right? It's left on, people like to sleep outdoors sometimes, and they call it camping, right? So we have houses and electricity. I'm not sure people are aware, right? That's something that's available to us. But also insides also have have bug infestations also, right? Here's a little cockroach friend. Imagine seeing that on an otoscope exam. Like, what do you got in there? Oh, okay. All right, so let me send you to an ENT specialist. Okay. So we got perforated eardrum, otosclerosis can happen, right? It's like arthritis of the stapes and malleus and such. And then we have sensory neural, right? So we have damage to the sensory organ or to the nerve itself, right? So the nerve is the cranial nerve 8, the vestibular cochlear nerve, and that could be a damage there, like a tumor, right? A trauma, you can do it. The sensory nerve is usually more common. That's where we'll talk about Meniere's disease, right? Which damages the vestibulum, the cochleum, can be with age, right? The hair cells with age die off. So these little hair cells that are in there, okay, they die with age, and they have to be able to move with vibrations, and based on those vibrations, we interpret that as some kind of sound. It's really crazy that it's just a little hair moving in the wind, and that little is you're like, oh, that's my baby crying, right? So that you can recognize those things, and the different variations in that will be sound or music even. Okay, so cochlea with age, which is called presbycusis, that's a hair cell death. You can accelerate hair cell death with rock concerts and motorcycle jet engines. That's why you want to wear ear protection, okay, in those situations. All right, so that's the idea behind sensory neural loss. Okay. So what are the symptoms of hearing loss? Hearing loss, right? That's an easy one. You got hearing loss. We can measure that in a lab. You probably do this in school, and they assess your hearing just like a scoliosis. Okay, come with me now. We got to check your hearing. So can my doctor do that? No, we got to do it now, right? So they check your hearing. They ask you to raise your hand if you hear left or right, if you hear a sound or not, and specific hertz, specific levels of sounds, right? Like dogs can hear really, really high. Kids can hear really high, and then at a certain point you start losing those high sounds, which happens with presbycusis, right? So it's bilateral also. Right, it's really hard to get earwax on both sides. It's usually, it's like, oh, you must have old age. It's like, no, they might just have, if they have hearing loss on one side, it's probably, impaction or something in the way that we have to investigate and figure out, right? So cerumen or foreign body, right? So again, back to presbycusis. That is a sensory neural, or is that a conductive loss? Presbycusis is damage to the hair cells inside the cochlea, right? So that is sensory neural, right? And it's usually, again, bilateral. Like you don't lose hair cells on one side compared to the other, right? Unless there's some kind of occupation that did that. But again, cerumen or foreign body that's inside the ear canal itself, that's going to be what kind of hearing loss? A conductive, right? It's usually on one side, right? One side is more impacted than the other, right? There's different behaviors that someone has that has hearing loss, right? Usually volume's up on the TV or music, they're always listening to things really loud. And then also there's fights that happen with their significant others, like turn it down, right? They're always listening to super loud. Someone asks you to repeat things, they have conversation, social withdrawal because nobody can hear them, and they speak loudly compared to someone else. Like I graduated from a nursing school who was a construction worker. He was always loud. So and he had hearing loss from his construction days, right? And their speech may eventually be affected because you base your speech based on what you hear. Okay, you lose high-pitched tones first, right? Especially presbycusis, and then tinnitus can occur, and that's a ringing of the ears. So the next slide, we go more in depth into tinnitus and how that works. Okay, so because we have medication, because sometimes tinnitus can be just due to old age or some kind of cerumen impaction and such, but it also can be a result of actual problems, like a vascular problem of some sort. Okay, so diagnostic tests. Well, what's an otoscope do? It scopes the otos, right? It's going to go look at the ears, see if there's maggots growing there, cockroaches, or something there in the ears. That's going to be your first step, right? And then you get all your little tiny instruments out to pull it out, right? All right, foreign body, is there an infection there? They have otitis media, or they have a swollen membrane full of fluid in the inner ear, right? Or sorry, the middle ear. That's going to be a conductive hearing loss, right? And then audiogram, that's what we did in school to assess how much hearing loss do they actually have, and do they need a hearing aid? Okay, and then tuning forks. All right, so tuning forks are designed to detect is there a conductive hearing loss or a sensory neural hearing loss. So we do a tuning fork test, right? So you bang it, you can barely hear it, but if you put it to your forehead, it should go to both sides, right? And I make a W, right? And that's Weber's test, right? Is where it goes to your forehead, and it should go both sides. Should be able to hear it nicely on both sides. And if I do, that means I have good hearing, right? Usually things conduct better through movement compared to air, right? You've ever seen A Quiet Place, right? You make noise and it can conduct through the ground or conduct through water, conduct through things. That sound conducts better through like the skull, for instance. So if I had cerumen in one ear, right, it would conduct better to that ear, right? It's like, oh, you must have a conductive hearing loss, right? So Weber's test assesses for conductive problems, right? It's not going to assess for hearing itself, right? That's what Renee's test is for. So Renee's test is the other option, and with that one, you strike the tuning fork, you put it on the mastoid back here, and when it disappears, when that goes away because I have conductive hearing loss, or sorry, when I have conduction, I should be able to hear that nice and clear, and then I put it to my ear, and I can still hear it. That's good. I have normal hearing, right? Because air conduction lasts longer than bone conduction in someone that's normal, right? Someone that's normal, their nerves work and they can hear air conduction, right? They can hear the sounds traveling through the air, right? But if I had impaction, I would not be able to hear on that side. If I have a bunch of earwax on this side, I would not be able to hear it. I would have a conductive hearing loss, right? It could also see if you have a sensory neural loss because maybe I hear it better with conduction compared to air conduction. All right, so if you want to play with this, right, there's some alcohol pads here from 1972, right? See, this box is I asked for an otoscope, and I forgot mine at home, or an otoscope. I asked for a tuning fork from the lab, because I forgot mine at home, and that's what I got. It just looks like it was fresh out of 1972. So this one it's a little easier because it will actually ring for you. You just wipe it off. We're not going to spread MRSA with this. This one you have to hit a little bit harder, but you can still hear it to see. Okay, so it's Weber and Renee test. You can just So you put it to your Med-Surg process, that's what? Weber or Renee?
Renee.
Bring it along.
Renee, you should be able to hear it conduct.
He hit it, he said it's a C.
It's a note C. C, right? So that's the idea. It assesses bone conduction, conductive hearing loss versus what other kind of hearing loss? What's the other kind of hearing loss? Conductive or sensory neural, right? So that's the idea behind Weber and Renee tests, right? And you can do a quick little algorithm, right? First, with Renee, you hit it and you should hear conduction. If you hear conduction better than the air conduction, that means you have a problem. Like you could have there's something in the way. Okay? Yeah. Now, if you don't hear anything, you don't hear conduction or air conduction, bone conduction or air conduction, then you have sensory neural problems, right? All right, so that's the idea behind these tests, to detect if they have sensory neural loss or conductive loss. All right, so this feels like tinnitus also, right? So tinnitus is the ringing in the ears, and you get to the point where it's just very, very annoying, and you can't, it's buzzing, roaring, clicking, whistling sounds in the ears, and you can't get sleep. It's like, oh, I can live with that. It's like, well, now you can't sleep, and now you get anxious, and you get your fibromyalgia all out of whack, right? And then two types, right? There is the subjective type where only they can hear it. There might be ear pathology like cerumen or something, or foreign body or something, but the one that we can actually do the diagnostic test for is the examiner can hear it too. It's like, oh yeah, I do hear a whistling. I do hear a hum. All right. So, for instance, like hypertension, you can actually hear the blood being so turbulent that you can actually hear it externally. Okay. Otosclerosis, that's where your stapes and malleus and all those other fun things. You can actually hear them vibrating. Okay. All right, and how do you fix it? Well, tinnitus comes from a different area of the brain compared to your cranial nerve 8. The reason I point that out is because cranial nerve 8 we want to inhibit when we have vertigo, because vertigo comes from. Yeah, this is hard to do with a little sleep too. Okay, it's a lot of fine motor movement. All right, so yeah, cranial nerve 8 is what feeds your vertigo, right? So when we talk about vertigo medications, all those are inhibiting cranial nerve 8, which is actually opposite of tinnitus. Tinnitus comes from different areas of the brain. But the key takeaway is that GABA drugs, GABAergics, like benzos, all right? Those are ones that are going to inhibit both vertigo and also they're going to inhibit tinnitus, right? So it gets tricky when someone has tinnitus, but then if you give the medications, they might get vertigo and vomiting, right? Because with vomiting, you want to stop dopamine, right? Sorry, you want to potentiate dopamine, right? And you want to, so that can be an issue with these guys, okay? Histamine, acetylcholine, dopaminergics will induce vertigo, induce nausea and vomiting, all right? So it's like a double-edged sword, okay? So that's the idea behind these guys. GABAergics will be used for tinnitus. Right, there's not really many non-pharmacological things you could do besides the underlying cause, right? If they have cerumen, they have high noise levels, right? They always like to hit every Taylor Swift concert every weekend. It's like, you know what? You should be. I know you're a Swiftie, but let's back it down, right? So also triggers such as stress, E2H, caffeine. I guess that's also just something non-pharmacological you can manage. A lot of those things will raise your blood pressure too. So everybody has tinnitus right now, right? All right, so hearing loss. What are some interventions you can do for hearing loss in general? This isn't tinnitus. This is specifically like hearing loss in general. So what can we do? Do we speak high or low? All right, a lot of us in the room might have quiet voices, but also might have high-pitched voices, right? It's like, oh, I'm going to take care of you today. It's like, well, I can't hear you, right? So I need to be able to hear, so your older population needs to have deeper voices, right? I use it all the time when I'm trying to call a student or call a nurse down the hall. I say, hey, Lily, come over here. They can hear me a lot better than if I say, hey, Lily, can you help me out? But that's not going to be able to hear you as great, okay? So using a low voice can help you get people's attention more than if you use a high voice, your high cute voice, okay? So also with older patients, you want to be lower, not louder as well, right? I use a louder voice when I call them on the hall because, you know, they got Zambonis going, they got people talking, there's a whole lot of different things you have to battle, okay? If you also want to, when you're talking to someone with decreased hearing, you don't want to repeat the same thing over and over. It's like, did you hear me? We're going to do a bath. Did you hear me? We're going to do a bath. Did you hear me? We're going to do a bath. You have to rephrase it. Use different things. That way they can assemble different words and put the message together in the brain, right? You want to get their attention, right? You're not going to go, all right, bath time. Or no, you're going to tap them gently on the shoulder. You're going to try to get their attention, right? Versus clapping. It's a little bit rude, all right? You want to be face to face, right? You want to be stick up behind them. It's like, hey, it's bath time, right? With your low, deep voice. You want to, I'm not sure why I got the bath on bath time, but so you want to get their attention from the front, right? You want to make sure they can see you, right? You want to, so they can see your lips, so you're not going to be wearing masks, right? At this point, if they really can't hear you, you want to drop the mask so they can actually read your lips, right? They made these clear masks back in the day. They worked out great, right? So those are also options, I guess, right? And you also want to make it quiet, right? So the Zamboni, you tell the Zamboni, hey, you need to stop the Zamboni, right? And then they can then hopefully hear you. You can close the door, you can close the curtains, so they can make the environment as controlled as possible, okay? So the other thing is treating underlying causes, right? So if you have osteomyelitis, you give them antibiotics. You'll talk about that in peds. And then autoimmune situation, steroids, that's all I get to give. And then ototoxic drugs, stop those. All right, what's an example of an ototoxic drug? Cisplatin, right? Not everybody's on cisplatin, unfortunately, but that's probably something like you look at the antibiotics. I got, if a patient reads the call, but I got tinnitus. Like, let me just check your MAR, right? And then you go and you see that they're on gentamicin. That might be causing it, right? Or azithromycin, for instance. All right, Ceremin, right? We're not going to be using Q-tips for Ceremin. It's on the recommended list. There are surgery options. So someone has really profound otitis media. They can do, they can put little drains in their ear and such. There's different options to reconstruct the membrane if they have to. And then hearing aids. So hearing aids are super expensive. So when someone loses a hearing aid battery or a hearing aid, it's like losing like a Honda Civic, right? It could cost like $3,000 to $6,000, right, for the hearing aids. So it's a big deal to lose these guys, right? So different care and tips you want to give them, right? There are different varieties. There's in the ear, behind the ear, in the canal, right? These are different varieties of hearing aids, but basically what they're doing is just amplifying the sound, right? They are making the sound go through little tubes. Usually the tubes are usually more beneficial, and the tubes will amplify the vibrations, and then it will go to, and the patient can hear better, right, with a hearing aid. So different things with battery care and such, right? Make sure they turn their hearing aids off, and don't after they're done with it. Make sure they put it in a safe spot. Make sure they don't refrigerate their batteries. I guess there's all kinds of myths out there about what to do and not do with your hearing aids, right? Keep your hearing aids charged so you don't run out of hearing aids after a while, or you can't hear after a while. You can't hear the high-speed chase that's going down to your highway, and then just driving, and then you get sideswiped, right? And then cochlear implants, which I think is amazing. It like uses machine learning to understand what a cat sounds like, and then puts little vibrations of cat right into the ear directly. Like it like puts little wires into the hair cells of the cochlea itself, or puts directly into the temporal lobe, so they can actually tell, oh, that's cat, right? So I think that's ridiculously crazy. Okay, so it's a processor that's installed that's able to interpret this information from the outside environment. It takes outside signals, like, oh, that's bird signal, and it goes to the brain, and it matches what bird sounds like. Okay, so our last little section is Meniere's disease, or Meniere's. All right, so Meniere's disease used to be called emphylymphatic hydrops, and hydrops is a term from the 1800s, where they had that's just another word for edema, right? So if someone came down with hydrops, they had dependent edema, right? So you might hear that in your novellas. Anyways, inner ear distension, right? Due to buildup of this lymphatic fluid that's circulating around in the vestibula. There should be a little bit of fluid, so things are moving around, right? Because usually if you look there in the bottom middle, that fluid will, when it turns to the side, it's like, oh, my head's moving to the right. When I turn to the right, my head's moving to the right. All the fluid goes to the right. All the fluid goes to the left, and it's in 3 dimensions, which is pretty crazy, right? So what can put you at risk for Meniere's? Head injury, infections can put you at risk, smoking, ETOH, but salty diet is usually the number one cause. Just like you get salty, you can get swollen for Thanksgiving, you could get endolymphatic hydrops. You could tell everybody when you're full on Thursday, it's like, oh, I got endolymphatic hydrops. Okay, So it's swelling within that vestibular cochlear apparatus. So it's vestibular cochlear. So it's all, vestibula is for what? For balance, right? And cochlea is for hearing. So they can have some hearing loss with Meniere's as well, right? And of course, the vestibulum gets swollen, it gets overstimulated. Overstimulation of the cranial nerve 8, the vestibular portion will cause vertigo, right? Also cause nausea and vomiting too. Okay, so that's the idea behind Meniere's disease. All right, so what are the symptoms? You get vertigo. So we kind of combine them there, so that way you just have one slide to rule them all, right? So it has a, vertigo is a result of Meniere's, but vertigo can also happen from other sources, right? So 3 symptoms of Meniere's. How do you know someone has Meniere's? Well, it's on one side. It's hard to get Meniere's on both sides, right? They got the tinnitus and they got the vertigo. It can be a chronic situation they deal with, like due to trauma or something. But if it's a salty diet, we tell them to stop with a salty diet, right? But otherwise, initially, they're going to have the sensory loss, right? Is it sensory neural or conductive? It's sensory neural. It's the vestibular cochlea, the inner ear that's being affected, right? And then they got tinnitus, and tinnitus is the ringing of the ears, right? Because it's being overstimulated. And then the vertigo as well from the vestibular apparatus, right? So they have all of this vertigo input from their nerve into the brain, right? And because of that, they can also have nystagmus. Nystagmus is the movement of the pupils, right? So pupils moving left and right can be a situation, but you should never have pupils going up and down. That's a sign of like a tumor in the brain or a huge problem in the brain, right? But going left and right could just be simply nystagmus, or there could be other untoward problems that might be happening, right? Also, the vertigo and tinnitus will cause SNS to fire off. It'll cause a lot of sweating, abdominal pain, diarrhea, etc. These guys are not going to want to move a lot because the vestibulum is all super swollen. They are like over the edge. Any kind of movement is going to cause some problems, right? So how do you know someone has Meniere's? Well, you can do like the Turkish priest over there, and you do what's called the Romberg test, right? And this Romberg test says, hey, are you dizzy now? You dizzy now? Are you dizzy? All right, show me the money. All right, so that's a Romberg test you do to assess if someone it gets dizzy after you tilt them upside down, right? That's the real one right there, right? And they say, well, do you have some vertigo? Do you have any spinning, which is vertigo? Do you have any tinnitus? Do you have any, dizziness? That's a sign of Meniere's disease, right? We do caloric testing. You'll talk about that more in Med-Surg 3. You do that to assess brain death. You put cold water or warm water into the ear canal, and the eyes should do nystagmus towards that stimulus or away from it, depending on whether it's hot or cold. All right, audiometry to see if they can actually have hearing loss in one ear or not. Okay, so non-pharmacological, there's ginkgo biloba you can recommend, right? It'll help with vertigo. Sorry, this is for vertigo on itself. You can help with Meniere's disease too, which has vertigo. But just vertigo in general, you can encourage ginkgo biloba, which has bleeding risk, right? Which is something that's, we're supposed to teach you all these alternative medicines as well that are out there that interact. It's all in your drug guide. Like, oh, this one can interact. So there is a method to how to figure them out sometimes. But if they have like plants. All right, they're eating plants that are being ground up, and it's a alternative medicine. Well, plants are cholinergic, so they have like diarrhea, sweating, vomiting, and such. So there's a way to kind of work it out. But otherwise, you just have to, I guess, okay, interacts with that. All right, so avoid sudden movement. Obviously, guys are not going to want to move anyways, but if someone has vertigo, you're not going to encourage them to go hiking with you. All right, clutter-free environments, including no driving. Right, so they want to make sure they're fall risk, especially if they're older in their 60s, 70s with vertigo. Want to make sure their environment is as clear as possible. Reduce stresses, right? Acupuncture, exercise can help. Limit the SNS stimulation with caffeine. Not stop smoking. Aspartame is linked to it. It's ototoxic. And then vertigo itself. How do you fix vertigo? Well, remember we talked about tinnitus and vertigo share the same treatment with GABA. So if we give GABA, it's going to inhibit, as GABA is always inhibitory, and promoting GABA, so with GABAergic drugs, which are your benzos, right? Those guys are going to inhibit the nausea, vomiting for one, but also the tinnitus and also the vertigo. But other than that, it's opposites. Like we give histamines for our patients with tinnitus. With these ones, we give antihistamines. Okay, we give antidopaminergics because these guys usually are vomiting also, and remember our nausea vomiting meds are pro, or what are they? Are they pro or anti-dopamine? Usually pro-dopamine. They're dopaminergic, right? So that's going to help here is a little bit, but these guys for tinnitus. Here we do antidopamine, so it can be at risk for vomiting, ironically. Okay, so Meniere specifically, low sodium diet, because sodium salty foods can cause it. So low sodium diet is recommended for these guys. And then what else? Diuretics will help reduce and pull off the fluid. Someone comes in with dependent edema and high drops in the 1800s. They didn't invent Lasix to the late 1800s, but either way, they would give them some fluid, or get rid of the fluid by giving diuretics to make them pee. Okay, and then ironically, there's a histamine drug that we give to stop Meniere's. Okay, surgical wise, how we can fix it? Well, here's like the stepwise pathway: salt-reduced diet, right? And then what we can do next is, if they really don't like their Meniere's, it's like, I got an option for you. I can give an injection right into your vestibulum, and we're going to put gentamicin there. It's ototoxic, so we're just going to annihilate that ear. Okay, and if that doesn't work, they still have the tinnitus, they still have the vertigo. We can go in there and we can just kind of shave it out. We're just going to take out the whole apparatus itself. Right? Obviously, that's much more severe Meniere's, but that is in the cards. They can do intracochlear, intravestibular injections of gentamicin, or they can just shave out the whole structure all of on its own. Okay, so that's the idea behind Meniere's and vertigo, and they can Meniere's has hearing loss as a feature as well. Okay, all right, so that is sensory neural.